Like this.
Yeah, she's like, I mean, it's like, like, you're all of Dr. Fisher.
Hello. All right, start this thing. So yeah, most exciting talk of the year for sure. Lateral epicondylitis, elbow neurologic lesions. Going to talk about basically lateral epicondylitis and ulnar neuritis on this topic. So tennis elbow, pretty much extremely common that people see really in every kind of clinic. I mean, this is hand clinic, sports clinic, shoulder elbow clinic. Very common. Thankfully, a lot of it will go away in time, but a couple kind of basics here, and we'll go through a little bit of literature on what's out there currently as far as treatment goes. So equally common in men and women. Does happen in tennis players, but the vast majority of people that you see lateral epicondylitis in is non-tennis players. But heavy laborers, it's common in repetitive gripping, typing, that kind of thing. The actual injury mechanism here is some sort of tear or microvascular abnormality at the ECRB origin. And it creates this classic, OIT question of the angiofibroblastic hyperplasia or dysplasia. But the idea here is that you have a chronic tear of the ECRB origin, and the body attempts to heal this over time. And due to the continued use of your forearm extensor musculature for everyday use, it goes on to form this type of tissue that is painful. It's some sort of scar tissue kind of thing. There is this, I know, I heard Sean O'Driscoll talk about this a lot, but there is this thought that this might be in the continuum of lateral elbow instability, and there is a high rate of missed posterolateral rotatory instability injuries in patients that have been treated for chronic tennis elbow. The only reason I really bring this up, I don't know how you guys feel about this necessarily, but this is just something that I keep in the back of my mind. When somebody comes in with classic appearing tennis elbow, and their exam seems like that, I'm always considering posterolateral rotatory instability as well, especially if they've already undergone some sort of treatment and this is a continued issue. As far as the exam goes, Michael, this is something that you're going to see if you haven't seen it already, but the tenderness palpation over the lateral epicondyle or just distal to that is pretty classic. But really, the elbow extended and then wrist and finger extension and pain with forced finger extension, wrist extension over the lateral aspect of the elbow is really pretty sensitive and specific for this. As far as treatment goes, so there's depending on what you look at, there's about a 95% success rate with non-operative management, and success defined as relief of pain. These symptoms can last 1 to 1.5 years or even longer sometimes. Can be pretty painful, but again, people a lot of the times can still function with this. So that's part of the reason why we push the vast majority of people to non-operative management with lateral epicondylitis because they have a 95% success rate with non-operative management. As far as treatment goes, I'll kind of go through this with my own algorithm here a little bit, but for me, first line of treatment, depending on how long they've had symptoms, is a home stretching program versus possibly physical therapy. I'm not sure how useful physical therapy really is, other than some of the modalities that they can do. But the home stretching program, for me, I do elbow straight and then wrist extension and then finger and wrist flexion I have them do that 3 times a day. And then I'll usually tell people to go on Amazon or Walmart or Walgreens or something like that and get this counterforce strap to use during heavy hands-on activities. For me, when we do these modalities, at least initially, most people feel like the pain improves enough that they can get by in their daily living. So this is what I'll pretty much start everybody with. Physical therapy, like I said, they have some other modalities such as dry needling, iontophoresis, that sort of thing that maybe has some evidence behind it that's a little bit more in depth than just the home stretching program. Injections, so there's a couple different ideas as far as injections go. So corticosteroid injections have fallen out of favor to some degree. To be honest, like looking through the literature on this, there's not a lot to support corticosteroid injections, but there's also not a lot to say that corticosteroid injections are worse than PRP or dry needling, that sort of thing. But generally speaking, corticosteroid injections are very helpful for the immediate phase of pain relief, but as far as long term, it doesn't seem to have much of a result. And there's some data showing that possibly extends the length of your symptoms. But this is a randomized prospective controlled trial. I think this is out of like Turkey or something like that, but so you can take what you want from it. But anyways, they randomize people to doing dry needling or corticosteroid injection. If you look at the kind of pre-intervention pain scores and post-intervention pain scores, they both did very well, but the dry needling group did a little bit better. And then if you look at the long-term results, they were pretty similar. I was looking through the last couple of days at a lot of these kind of higher level studies on corticosteroid injections. It's pretty all over the place, to be completely honest. So I pulled this meta-analysis. This is relatively recent. And this just looked at level 1 and level 2 studies over the last 15 years or something like that. And basically what they found, you can kind of see on these plots here. So the 1 month results, if you take it as a meta-analysis, the corticosteroid group did slightly better than, this was PRP versus corticosteroid, than the PRP group. But if you look at the 3 month and the 6 month, it seems to be pretty across the board in favor of PRP over the corticosteroid injection group. So, for me, what I take from this is and this will get into my treatment algorithm in a little bit here, but if somebody's come in and they've already tried some of the stretching, physical therapy, that kind of thing, or they've had symptoms for a while, I have a discussion with them of, okay, what's the next step here? Is it injections? As I kind of mentioned before, I try to avoid corticosteroid injections. PRP, I say that there's some evidence that supports PRP, but it's by and large, with the exception of some workers' comp cases and TRICARE, it's not really covered by insurance. And in this facility, it's about $500 for people to do that. So, that is very cost prohibitive for a lot of people. And the evidence behind it is not fantastic. So I have a hard time pushing people towards that, but for some people, $500 is not a big deal. So that kind of brings us to a little bit going up the ladder, more invasive treatment options. So there's percutaneous tenotomy. So this can be done with just like an 18 gauge needle and ultrasound guidance. But probably over the last, I think 8 years or so, there's been this 10x percutaneous debridement device. So the way that this works is you don't technically have to use ultrasound. That's how Joe Boo did it. We just kind of poked around in there. But the idea is use ultrasound. You find the area of tear at the ECRB origin, and then you have this thick needle device, and this can be done in the clinic. And it uses like an ultrasonic frequency at the tip to break down the tissue. And then it also has an irrigator aspirator device that can basically remove all of the tissue that you've just debrided. So it's more or less a way to do a percutaneous debridement. Obviously you can't do any sort of percutaneous repair with this, but the results are pretty decent. So I will say, I actually talked to Nick Monson about this a little bit. There are pretty minimal studies out there that are not industry biased on this. So I'd be a little bit hesitant, but again, talking with a lot of the non-operative people here, the results seem to be pretty favorable. And people that I've sent to have this done have not come back to me for surgery. So hopefully that means that it's working. But this is an insurance pays for it. Yeah. I don't know. I mean, if you guys have seen anything different, I have never heard of anybody not have insurance pay for it. But that's also it's a little bit more invasive than PRP. But again, it seems that insurance pays for it. So I've been pushing more people towards 10X. But I don't know. The way that I usually do it here is I say, why don't you go meet with one of our non-operative providers and they can talk about it. I don't know. It's a good question. I actually don't know.
You don't put a stitch.
I think they just put the needle in. Yeah. Yeah.
I think they do use it like.
It's a pretty big needle. It's like 14 gauge or maybe even bigger size needle.
I don't think it works 100% of the time. I usually tell people it's an 80% success rate. I think the most important thing to tell people with this is there's a recovery period associated. It's not like getting a shot. When they tell people when you have to wear a sling for a couple of weeks. But it's
like 2 weeks though, and then they let them return to all activity is what I've heard from Monson, but I don't know if you've heard. Yeah. I think that's also somewhat true with PRP. Maybe not the sling part, but the recovery process, generally people are saying 4 to 6 weeks for recovery after a PRP injection, whereas a corticosteroid injection, it's like immediate.
We found anything studies about it.
Yeah, so this actually, again, this is a longer term one, or maybe that was the next one. No, sorry, this one's PRP versus 10X, and there's essentially no difference between the groups in this group. But this was a longer term study. Again, this was a little bit industry biased, but this was 3+ years. I think the average was like 4.5 years or something, and it was like 100% satisfaction. But basically, all of the 10X studies that I've looked at, yes, they're biased, but they report. I think one of them showed somewhere like a 14% rate of requiring surgery, but as far as like ligament injury and that sort of thing, nothing is reported on it. I mean, it'd be a little bit concerning, obviously, especially if you're not using ultrasound. But anyway, so this is 3+ years. It seems like it works. The data behind it, it's not great as far as like quality of data, I would say. And then, oh yeah, this one. So this is that 3+ year follow-up one. So the only thing that they noted on here is that patients that ended up having physical therapy in addition to the 10X procedure did do significantly better, which again, I think is a little bit different than what we think sometimes with injections, that, you do an injection, you feel better. So if you are going to do this, you should have people do physical therapy afterwards as well. Just froze it up here. All right, so then we get to surgery. For me, this is absolute minimum that I would consider surgery is 6 months, and they have to have failed some sort of conservative treatment. As I mentioned before, you always want to evaluate the lateral intercollateral ligament. That's true both in clinic as well as in the operating room. I get an MRI on everybody that I'm considering surgery on just to make sure that LECL looks okay, see what sort of ECRB tear that you're looking at there. The other thing to keep in mind is there's radial tunnel syndrome as well, which is PIN compression. That's also relatively nearby here. So you just have to make sure you feel good about your exam. And this is another one of the reasons why I get an MRI. If the MRI looks completely normal, sometimes I'm a little bit concerning. As far as surgical treatment options, so there's kind of a whole slew of these. There's tenotomy. There's tenotomy with like a side-to-side repair of the ECRL. You could do an arthroscopic release. you can do an arthroscopic release with a repair, or you can do an open debridement with a repair, which is generally what I do. I think that's what both of you guys do as well with an anchor. If you do this, is that what you
That's
do?
what I do. And for me, when I compare it, it's interesting because I'm not fully again sure what the length that stems from the curse from this operation because so I release the ECR with him. Then what I do is I repair the ECRL and whatever EDC back to the footprint of the ECRB. The anchor goes into the ECRB, but I actually release the ECRB. Usually there's pendant tissue in the ECRB. I mean, you can't, to be able to stretch the ECRB back up after you cut away the pendant tissue becomes very hard to do because there's even oftentimes a centimeter of tissue that's just gelatinous, not new tissue. Right? So what I do is the anchor goes in the bed of the ECRB, and I'm basically repairing everything else that's from the more superficial ECRB back. Whether or not that makes a difference, I don't know whether it comes to the scroll element. But I have scoped in the past, like I first probably only took 3 or 4 years that I treated Epicondylitis because of what Ken was doing with the race.
Yeah.
It's simple, it's easy. But I had some failures. And the failures, what I did was I went back and did an open ECRB repair, just like this. And my thought was, is it something? And every time that I went back and scoped it, there was no tissue. It was attached as lateral humerus in that area. And so I made the presumption that it must be that there's some lack of tissue or healing in that area is why patients actually have work on symptoms. I don't know, but since then, what do you know?
Same.
Yeah, I pretty much do the exact same thing. I'll show you a picture here in a second. So real quick, this study was trying to look at that as far as doing, again, if you're doing it through a scope, you're really just releasing it, right? If you're doing it open, you can at least repair the ECRL side to side is kind of the idea. Personally, I feel like if you are just going to be doing a side-to-side repair of the ECRL, you're probably going to shortchange how aggressive your debridement is. That's how I feel, at least. So that's why I use an anchor. But this looked at that. This is randomized controlled trial. It was 68 patients, and they found a significant faster recovery in the anchor repair group for the. So basically, the scores were better at the 1 month and the 6 weeks and the 3 month mark. But when they looked at everybody at 1 year, as far as return to work, quick dash, all that kind of stuff, it was the same. Side to side, but this was an actual side to side repair. This is a patient from last year, and this is why I put an anchor in. So this was like I literally incised the skin, and I was staring in the joint. And this was somebody that had a prior repair, and they had a side to side repair with no anchor. But this is part of the reason why I put an anchor in there. The other reason is we know probably the biggest issue with this surgery is possible LUCL origin injury. And with my anchor stitch, one of them, I basically run up and down where the LUCL is just to sort of reinforce anything there. Or if there's some sort of subtle posterolateral rotatory instability that I'm missing, I'm at least tightening up the lateral side. But I just feel like, I can get a very aggressive debridement and feel pretty confident that I'm repairing all of the tissue that's there. And I agree, the actual ECRB that's left a lot of the times is pretty minimal. So it's mostly I'm repairing ECRL or EDC or whatever is kind of nearby. But I've been doing an anchor with that and had pretty decent results. Complications, kind of just said this, but hydrogenic LUCL injury and posterolateral rotatory instability. Missed radial tunnel syndrome. To be completely honest, I haven't. I have missed it myself, but I have not really seen this. It seems like it's relatively rare, but the idea is the site of pain is basically where the PIN is entering the supinator. So, that's very nearby area, and it's predominantly a pain type syndrome. So my algorithm, again, this is very much patient dependent and what they've actually done. But generally speaking, if it's less than 6 months, or if it's more than 6 months and they really haven't tried anything, I have them start with at least some home exercise and stretches and the counterforce strap. If it's been going on for greater than 6 months and it's pretty significant, if they haven't done any prior treatment, I'll a lot of times actually send them to formal physical therapy, have them try dry needling. If they've already tried prior treatment, by this, I mean like physical therapy, stretches, corticosteroid injection, something like that, I'll send them for a 10X versus PRP referral. And I've kind of been leaving that discussion up to the non-op provider that's going to be doing it. But I do kind of tell them about the two options there. If it's been going on for greater than a year, or really 6 months and they've already tried and failed a more aggressive treatment option, such as 10X, then I'll consider surgery for those patients. Again, like I said, it's a little bit dependent on the patient, but I end up doing these about maybe 4 a year is what I've done for the last 3 years. I don't know what you guys are doing, but it's relatively uncommon. I think with having somebody here that can do PRP and 10X and that sort of thing is really kind of minimize the number of people I've sent to surgery. But anyways.
I'll pay at the rate of
Oh yeah. Okay.
patients are paying. Find someone late and they get referred to you.
Interesting. So I haven't done that because, well, have you seen anybody back for that after that? Do they get, because they get a PIN palsy from that injection, right? Or I don't know if it's really a palsy, but
I see the back.
I'm clearly had patients.
yeah.
I think that-
For me, it's that their pain. So it's typically more anterior and more distal, is what I think symptoms are.
Yeah.
The other thing is me, so it's helping as well. So posterolateral is typically intraarticular. Intraarticular syndromes, which can occur concomitantly like lateral epicondylitis. And so there's a group of surgeons who used to open posterolateral. So in the basically, if you want to think of posterior to the lateral agreement, when you're doing an open agreement, to be able to excise any intraarticular inflammation around the cranial head, posterolateral, similar, and then what can you say is scoping. If patients have a pre-op exam consistent with the see not only scope front of them, but PCR areas, we put that scope into the posterolateral posteriorly to be able to read around. To me, that's really unlimited. Clinically, I haven't seen it, but again, when I was a resident, the hand surgeons, that's what they're really was based on this exam. The thing that I have found is that the diagnosis that's not here, something like that. So
Yeah.
the other laterally based diagnosis that should get if you're in like an epicondylitis. Like the symptoms typically for me are posterolateral, that's when they have AMT, CRD. They usually have a positive puncture inflammation test. And so for me to rule out those two diagnoses, those patients get I'll take a diagnostic injection to see if they have from like the symptoms and stuff, say like they have a serum injection, and then obviously have the kind of reactions like that. Then it's still
Yeah. I guess I didn't mean to say that it doesn't exist. I just haven't really seen it on my own. But I do agree. Like, so if their pain is more posterolateral, then yeah, I think an intraarticular injection makes sense. I probably have gone to getting an MRI faster on these people than doing an injection, but I have not sent anybody for an actual PIN injection, but maybe I'll start doing that.
the thing about it.
Mhm.
I'm always. Just have a lot of
You worry about that. Yeah, I agree. So that's kind of part of it. It's like their exam looks like lateral epicondylitis. I get an MRI that shows there's like a 70% ECRB. Like, I feel awesome about it. Oh, interesting. Cool. I'm just going to go through ulnar neuropathy at the elbow at least quickly, and then we'll get you guys out of here over to conference. So ulnar neuropathy, again, some of this is relatively straightforward, but numbness in the small finger and the ulnar half of the ring finger, hand weakness, intrinsic atrophy. You can also have isolated pain over the medial elbow and sort of an achiness over the medial elbow that can be associated with this too. Worse at night with the elbow bend. So before I consider surgery for these patients, again, a trial of conservative management makes sense, but I think I got these slides out of order here. But what conservative management really is for these patients, I have not had much success with physical therapy. Really, it's using a extension brace, especially at nighttime. People hate this thing. I've got ulnar neuropathy on both sides, and I just kind of sleep with my arms straight as much as I can. And I wake up with a numb hand pretty much every morning. But because this thing's terrible. But this is basically the book answer is the issue is when you sleep like this or like this, and you're putting compression over the ulnar nerve in the cubital tunnel. So this is the first step in treatment. I'll still, if people have symptoms, unless it's severe or they've got like muscular symptoms, muscular atrophy, that sort of thing, I'll still trial people with this. EMG, I have gotten an EMG basically on anybody that I'm considering surgery on. I don't, there are still some people that have obvious symptoms and a normal EMG that I have done cubital tunnel releases on. I don't know what you guys feel about this. Do you get an EMG pretty routinely if somebody has?
If there's atrophy or if there's all the time we get an EMG.
Otherwise,
I think the main reason why is to diagnose the rare patient with concomitant compression guions.
yeah.
If that patient should be referred to here.
So that's exactly why I get an EMG. Some of the times it seems relatively obvious on exam, but if they have an EMG that shows, ulnar nerve compression at the wrist, then same thing. I'll send them to hand for that. Anyways, so being kind of weird here. Surgical consideration for this. So if somebody comes in and they have muscle atrophy and it seems to be obviously coming from the ulnar nerve, or they have an EMG that shows severe compression, I'll pretty much go straight to surgery for that. Or people that have had chronic symptoms that have already failed conservative management as well. The point of this is probably, I think this is from OrthoBullets or something, but the point of this is that there's multiple sites that the nerve is compressed, and you really have to, if you're going to take somebody to surgery, you have to release all of these sites. So my incision is relatively large for this. You can do it through a smaller incision, but the ones that I've seen that have failed this, they have an incision that's like this long. The point is you need to release it all the way from the intermuscular septum proximally to the deep FCU split distally in order to have an adequate release. It's not just at the at Osborne's ligament around the elbow. So as far as options, you can do an in situ release. and I'll show a couple studies on these in a second, but in situ release, this patient actually ended up having a transposition, but this is the only picture I could find on my phone. But basically, you can leave sort of the deep adhesions between the nerve and the tissue, and then you release everything superficial. And again, you're going through all of those layers, but you're leaving the nerve in place. Subcutaneous transposition, this is probably the majority of what I'm doing for patients. But the idea here is that you create a subcutaneous flap anteriorly, and then you can release the nerve and then transpose the nerve into that flap. Generally, you want to do something to keep the nerve anterior. You can do a fascial flap that you can or fascial sling that you can take from the flexor pronator fascia and then attach it to the deep subcutaneous tissue. That'll create a sling. You can also do a fat layer that you can repair down to let the nerve kind of sit in a fat bed. That's primarily what I'm doing now. Patients that get a transposition pretty uniformly, if they have ulnar nerve subluxation or if they failed a prior in situ release, they're getting some sort of transposition. Submuscular transposition, this is from Green's textbook, but I have only done this once, and it was for a failed in situ release in a thin female. Basically, the idea here is you can put the nerve inside the muscle to basically keep it out of the subcutaneous tissue. The two reasons to do this, I think, so if somebody's already had a failed subcutaneous transposition or in situ transposition, it's reasonable to consider this. Or if it's a very thin patient and you think that that nerve is going to be sitting right underneath the skin and symptomatic for them, those are the two circumstances that I consider it in. There's definitely a higher complication risk with this. There's a high risk of infection and higher pain afterwards. So it's something that I don't routinely do. You can also do just a subfascial transposition where basically you're elevating the fascia and repairing that over. So it's not exactly submuscular. The submuscular transposition, I don't know how you guys do this, but usually I do sort of a Z. And then you have to elevate a lot of the flexor pronator muscle to actually transpose this thing. It's a pretty brutal surgery, actually. Whereas the subfascial, you're really not violating the muscle as much, but I worry that you're going to be tensioning the nerve too much when you do that. So looking at these different surgical treatment options, this was a non-randomized retrospective analysis. This is all military patients. It was 132 patients, and they were basically comparing in situ decompression to an anterior transposition, and this is also subcutaneous transposition. So the in situ release, this paper did show that in situ release was pretty significantly better as far as like the head-to-head, but when they did a multivariate analysis, there was no real difference. The other thing here is this is non-randomized. It's a very select patient population. So, you know, take what you will from it. But this was a randomized prospective study looking at in situ release and submuscular transposition. So it's only 44 patients. The clinical outcomes were similar. Probably the biggest thing here is 3 out of 21 patients in the submuscular group got infections, where 0 in the other group didn't have any infections, which was significant. So there are certainly more complications associated with submuscular release. And the last one here, so in situ decompression versus transposition. This is a meta-analysis. Really, what you can see here when they look across, I can't remember how many studies. I think they had 13 studies or something. There's no difference in this one. I think Peter just walked out, but there's 1 or 2 studies that show a higher reoperation rate if you do an in situ release versus a transposition. The idea, it's kind of like if you've already done transposition, you're less likely to go back in there and revise them. But when you look at the clinical results, they're the same. I don't really see much of a difference here. So I think it's really pick what you want to do. Make sure you're actually releasing all of the nerve. The way that I do this is if they have any sign of subluxation of the nerve at all, or if they have like predominant, like some other concomitant elbow problem, like they've got a stiff elbow, you know, they're a pitcher or something like that, then I'll do a transposition. Otherwise, I'll do an in situ release. I don't know, Bob, if you have any thoughts on that.
You know, I mean, per total. Someone actually just does, it's just bursitis. The reason why I'm doing it's not because they have neurologic symptoms, it's because they potentially might be